Hi, everyone. I'm Dr. Bob Cho from Shriners Children, Southern California in Pasadena, California. I am honored to be presenting on behalf of the Scoliosis Research Society for Scoliosis Awareness Month, this question and answer session for patients and families. I am also honored to be joined by two of my friends, fellow members in the Scoliosis Research Society, Dr. Ryan Fitzgerald, who's at the Children's Orthopedic and Scoliosis Surgery Associates in St. Petersburg, Florida. Dr. Fitzgerald, it's good to see you, as well as Dr. Arun Hariharan from the Paley Institute in West Palm Beach, Florida. So we have a little bit of a bi-coastal thing here, and thank you guys for joining us so much. Today's session is focused only on children and adolescents with scoliosis and spinal deformity. Our hope is to have a subsequent session for adults who have spinal deformity and want to ask questions from our members. It's a big push for our society, which is the premier spine society in the world, to talk to our patients and answer questions as best as we can. So thank you guys for joining us. So just to get started, let's talk a little bit about our practices. So I'll talk about mine. I'm a pediatric spine surgeon. I take care of kids with spinal deformity from birth to 21. Most of my practice is scoliosis, but I take care of other spinal issues as well in kids. Dr. Fitzgerald, can you tell us a little bit about your practice?
Yeah, I'm in private practice in St. Petersburg, Florida, but we do all the orthopedic care for Johns Hopkins All Children's. And my practice is very similar to Dr. Cho's. Primarily, I do scoliosis surgery, but also all sorts of spinal conditions. Also, I do a lot of trauma care as well.
Thank you. And Dr. Hariharan.
Hey, good afternoon. Thanks for having me. I am also in Florida. I'm a pediatric orthopedic surgeon with special interest in scoliosis and spine care. I take care of children and young adults with all sorts of orthopedic and spine-related issues, but again, mainly scoliosis and spondylolisthesis and kyphosis.
Awesome. Well, now we know each other and we know what we do. I am happy to say to friends of mine, as well as fellow colleagues, I respect their opinions greatly. I want to say thank you to the people in the audience that have joined us. Abdul Majid saying Happy Scoliosis Awareness Month, and today is the International Scoliosis Awareness Day, I believe. And so I would like to address just general questions that we've gotten already about scoliosis. So, Dr. Fitzgerald, can you tell us a little bit about scoliosis? What do we think causes it, and what percentage of people usually get it?
Yeah, no, that's a great question, and I think it's one that we see often in clinic. First, to be clear, there are several different types of scoliosis. The majority of the scoliosis that we see is adolescent idiopathic. And so what adolescent means, it's kids older than the age of 10, typically going through their teenage growth spurt where scoliosis begins. And typically we know that with growth, we can see those curvatures and the rotation of the spine get worse. And typically, if we can keep those curves below 50 degrees by the time they're done growing, then that's a victory. Those kids are going to do well. And so that's the majority of kids that we see. But some of the other flavors we see are kids younger than the age of 10 that have scoliosis. And then also people that have scoliosis secondary to issues with the building blocks, or what we call congenital scoliosis. So those are the types of flavors. But again, the majority of them that we see are the adolescent idiopathic group.
Awesome. And then Dr. Hariharan, when do you think patients and parents should start to be concerned with scoliosis?
Yeah, I think that's critical in the initial management and long-term care of patients. The concern should really come not only from parents and coaches, but really from the pediatricians and the well-child visit. And a lot of states still, about 50% of the states still have school-mandated checks. And That's really where scoliosis is first noticed, and it can be anything from shoulder imbalance to rib cage imbalance. And getting in to see a specialist in pediatric spine care is crucial. And we have such modern techniques for care that getting in early and getting care for this can really avoid much of the concerns that we historically have had.
Yeah, thank you so much. We're getting some questions in the comments. I think one of the misconceptions is when you go to see a spine surgeon, they just want to do surgery on you. I think the three of us here will tell you that our goal is to treat scoliosis in the least invasive way possible that will have the best long-term result. I think that's all scoliosis surgeons, that's our mantra. So I think as far as treatment, not all kids that go to see a spine surgeon need surgery. In fact, most of the kids I see do not need surgery, and we're able to successfully treat without it. And so I want to just belay some of that fear. So just talking about bracing, so Dr. Fitzgerald, can you talk about bracing in kids, when kids should get it? What types of scoliosis should those kids have?
Yeah, absolutely. So back to finishing your earlier question, the thing I said about scoliosis, it's idiopathic still. So although we know there's all sorts of different gene combinations that can come together to cause this twisting of the spine, we still don't 100% know who is going to get it and exactly why they will, because people with similar genes can end up with scoliosis and then not as well. So that's going back to that. Now, as far as bracing is concerned, typically bracing is something that we reserve for people that have larger curves that are not yet to surgical indications that still have remaining growth. So what that is typically curves above 25 degrees with people that have a year or more of growth remaining. As far as bracing choices, there's lots of different types and flavors of braces out there, but we have the strongest evidence behind compression style bracing, such as Boston TLSO brace. This is all based off of some work that was done, a prospective study, so the highest quality of evidence that we can get. And we found in that study that about 30% of surgeries can be canceled by people bracing and bracing well. And the other thing we found from that study is the number of hours per day that people wear that brace is really important. So we know if you don't wear the brace at least 12 hours a day, that your efforts are not being fruitful. But every hour on average that you wear it past that, up until about 18 hours, you can get even more benefit. So for my patients, my goal is for them to wear their brace 18 to 20 hours a day. And the reason we shoot for 20 is we tend to overestimate how much we wear things. So if we're shooting for 20, we're going to ensure that we get to that 18-hour threshold that Dr. Weinstein found in his study.
Yeah, I totally agree. I think the amount of time you wear the brace, that's really critical. It's just like when I'm on the Peloton. I think I've been on there for 30 minutes, but it's only like 20. It's
only been 20 seconds. Yeah.
Exactly. Feels like 20 minutes, but 20 seconds. It's Dr. Hariharan. So when you get fitted, you're a parent, your child gets fitted with a brace, what do you want to see in the brace? Like what percent of in-brace correction?
The simple answer is at least 50% correction, but it's a little more complicated than that. It depends on where the curve is, what type of curves there are, if it's thoracic or lumbar, what type of brace you're using. Some people still, I think there's a question on there too, comparing day versus night brace. Some people still use a night brace. We've shown that, like Dr. Fitzgerald said, it's not as effective as the full-time daytime bracing, but due to various social reasons, and we know there's big social implications behind bracing, people prefer that. But typically speaking, about at least 50% correction after they've gotten the brace and have worn it properly for a couple of weeks. And we get an X-ray in the brace to make sure it corrects. And if necessary, we send them back to the orthotist and make adjustments.
Yeah, and sometimes it can be really painful. I had a family that came to our clinic for like a 1 p.m. appointment, and we're lucky because we have our orthotist, right in the same like hallway as my
Yeah.
clinic. But they had to go back and forth like 4 times just because we wanted to get that brace right. And sometimes that's just what it takes. It's just like if you've ever gotten anything else custom made, some it takes some take backs and some nips and tucks here and there, moving the pads around. So
Yeah.
and then I tell all the families, although we shoot for 50% or more correction, sometimes we don't get it. But I'll take 30% correction because that's better than zero. And I think the nighttime bracing, the biggest reason why I just don't think it works as well, like you said, is kids don't wear it as long. It's just the number of hours a day. I think that's really, really powerful. In that study that Dr. Fitzgerald mentioned, they didn't have enough data to show the daytime upright hours, mattering. But I think that the daytime upright hours likely dictate a little bit more of how much correction you're going to get because you're fighting against gravity, whereas when you're laying down, you're not. So, but that said, not enough data to support that. So Dr. Hariharan, so what do you think about locations of curves that do well with bracing? Do you think, lumbar curves, thoracic curves, high upper thoracic curves? What do you think? What works?
Yeah, that's a complicated question, and I think we're still figuring out the answers. But we know, for example, if the curve is an upper thoracic one above T7, the brace doesn't work well just because it doesn't go above the armpit, and you have to include the neck. And they used to do that back in the day, but we don't do it anymore, and it's not very good at correcting those curves. But luckily, those aren't the most common type of curves. And with the thoracic and lumbar curves, the brace tends to work pretty well, especially if it's a well-made brace and you have a good orthotist. And typically speaking, the lumbar curves are more flexible, so you can get a little bit more correction in the brace, but it also means that you're just correcting in the brace and it may not last as well as the thoracic curve. So I think that's why getting the appropriate brace made and getting it checked frequently and following up regularly with and without brace X-rays is super important, especially in a growing child.
Yeah, I agree. Dr. Fitzgerald?
I have a couple comments about earlier. So, like Dr. Cho said, these are custom molded braces. So the fun thing about it is, oftentimes you get to select your own brace, select your own colors, do those sorts of things. But sometimes they're just not right. So sometimes you get them and it's perfect and it's getting great 50% correction and life's good, and you wear that for a year or 2 years and you don't get a 50-degree curve that we know is going to progress, and life's good, we move on. But other times, like was mentioned, it takes 4 or 5 nips and tucks and adjustments to make that right. And so advice that I give my patients is, number one, look out in your own brace for areas that are problems. So problematic areas often are up in the axilla and the armpit. Sometimes they'll dig in that area. There's different padding options, different ways to flare that can make it more comfortable for you. Also, the bump that's on the front of your hip, that bump is prominent in everybody, and especially in young, thin people that are going through growth spurts, that area can be really problematic. So if you are wearing a brace or anticipating wearing a brace, and it's leaving a red spot that lasts more than 5 or 10 minutes, that brace needs to be adjusted. If it's where you can't wear it tight because of it being uncomfortable, then that's a brace that needs to be adjusted. And I think that, the key thing to know is you are also not the only person that's going through this. You may have a friend that's wearing it. If you don't, then there are thousands of people across the globe that are wearing braces, they're dealing with their scoliosis journey. And I think the part about this, outside of the physical and the rotational component and what's actually happening with your spine, is number one, finding community, and number two, that whole mind-body connection. Because I think whenever you grapple with that and get a hold of that and are able to optimize that people's scoliosis stories become inspirational and much better for people.
Yeah, I totally agree. And, we got some comments on Instagram about, sometimes it can be a depressing experience wearing that brace. But I think finding support for you to wear the brace, and the modern braces, I think, are better than in the past, where if you wear a t-shirt, often you can't even see that you have a brace on. I had a kid that came into clinic, couldn't tell the brace was on, except in the very back, wore away a little bit of the t-shirt just because the kid was wearing this t-shirt a lot and this brace a lot. So that made me happy, not that the t-shirt was worn away, but that the kid was wearing the brace a lot. So I do think bracing is our best option non-surgically. It has to prevent curve progression of scoliosis. It's not perfect, but it has the best data supporting its use. And, I want to urge any parents and families out there, any type of treatment that you're looking for, always, look at the data or ask about the data with your surgeon or with your physician. So I
Hey,
want
Bob,
to talk.
can
Yes.
I just say one more thing? So I kind of digressed a little bit when we were talking about like the mental aspect of scoliosis and dealing with your brace, but I recommend that, for my patients that are wearing braces, I say, hey, you need to really tell your friends what's going on. Show them your brace, help them to understand what's happening, because that's the best way, along with your family members and your surgeon, to build that support network locally to help you through that year to 2 years that you're going through this. And then the other thing is that within the SRS and within groups that are studying scoliosis, there's really great data that's coming out about the mental aspect of scoliosis and how we can partner with other healthcare people that can help through this process. And so I would say that, if you are having a tough time, talk to your surgeon about it and look for other support. So a psychiatrist, a psychologist, there are all sorts of cognitive behavioral therapy, medications, other things that can help you through this process. And just remembering that you're not alone and trying to pull people in to help you through that, because we find that people overall do much better whenever we're able to create that community.
Yeah, totally agree. Dr. Hariharan, when do you think kids can stop wearing a brace? Like, because they're in the brace, they're in it for a little while. When do you kind of take them out?
So that is also dependent on what we call the Sanders score, and you see that on X-rays based on the growth plates in the hands. And I used to stop bracing at about Sanders 5 or 6. It goes on a scale of 1 to 8, and the rapid phase of growth in children really is up to stage 5 or 6. And the historical teaching was it's okay to stop at 6, but again, there's more evidence showing that maybe not. Maybe you should keep it going. So what I've really done is, in patients who the brace have been successful, I've stopped full-time bracing at about Sanders 6. And again, you tell this by the hand X-ray, which shows up in many of our spine X-rays, and switch it to a nighttime brace until they're about Sanders 8. But this ends up being a total of about 2 to 3 years of brace wear, but a year and a half, 2 years is about full-time brace wear.
Yeah, I got to tell you, I was similar to you in that I would try to brace kids a little bit until about Sanders 6, maybe just starting Sanders 7. But there was good paper that came out of Shriners in Lexington by Dr. Ryan Muko, showing that the kids can continue to progress, especially if they're between about 40 to 50 degrees. About 50% of those kids will progress if you don't treat them. So I've gone longer with the bracing. Dr. Michelle Wellborn from Shriners in Portland talked about, perhaps we should go longer and look at other factors like blood markers. I think that data is forthcoming. I don't think we have enough data to support that yet, but I kind of use a combination of a lot of things. I use their growth chart. If the kids grow less than an inch in 6 months, then they're probably tailing off on their growth. We probably can back off a little bit on the bracing, but also the Sanders score I use as well. But I usually try to hit about Sanders 7 before I consider that.
Yeah, that's a recent change for me based on those papers you talked about.
Correct.
And in really young kids, Dr. Bugari asked here about kids diagnosed at age 7 and starting bracing. that's where it becomes difficult. How many years can you really brace a child for, right? Like, I'd be curious to hear your thoughts. I mean, can we keep a 7-year-old boy who might grow until 17 years of age in a brace for 10 years? I think if it works and it's keeping the scoliosis under control, I think it's totally reasonable. But maybe this is where things like Schroth therapy or exercises come into play to keep the paraspinal muscles and overall balance in good condition.
Yeah, I mean, I very much agree with you. It's hard to keep a kid in a brace for 10 years. That's almost impossible. I'm a big believer in, brace holidays, so if you're in a brace for a really long time and you're going to do this, I have a kid right now who I have been treating with infantile scoliosis, and kid's on a holiday right now because it's summertime and, kids want to swim. But, after about a month and a half, we're going to go right back into treatment. And so I think that you're 100% right. I wish we had something that was a little bit easier to tolerate than a brace for that long of a time. We just don't have the data to support a lot of other treatments. I kind of addressed that infantile scoliosis. So when we talk about infantile scoliosis, Dr. Fitzgerald, what ages are we talking about? What kind of treatments are we thinking about?
Yeah, so infantile scoliosis typically is less than 3 years of age. So those are kids that come in early on that are showing signs of rotation. And what we know about this is that this is a type of scoliosis that we can actually cure. And so especially if you have a younger child that's younger than age 2, that has a curve that's progressive, that's on the smaller size, typically less than 40 to 50 degrees, those are the curves that we have better cure rates with. So Dr. Mehta was doing this for quite a while. She collected great data and really figured this out for us. And based off that data, we really changed our style of treatment. Within that, what essentially we do is we do elongation, derotation, and flexion casting. And so that's a cast that does those 3 things to the spine. And what we know is that if you do that casting for somewhere between 6 and 12 months, that we can actually completely cure that specific type of scoliosis. But the keys to that, like I said before, is catching it early, and also making sure those curves aren't too big and getting out of control. Because overall, when you get too much twist, holding it in that more appropriate position doesn't always do the trick.
I totally agree. I treat kids exactly the same. Casting, earlier you start casting, I think the more successful you usually are. So it's important to really stay on top of it. Pediatricians are getting better about really looking at a kid's back, and if they see a curve, often they'll see this curve at birth, and then you can follow it real early. The youngest I've started casting on a kid is a little past a year. I think that's pretty early, but we were able to correct the kid within about 6 months. Like you said, earlier you start, I think the faster the treatment is. I want to just address some of the questions that we've been getting. So Dr. Hariharan, do you want to talk about kind of scoliosis rehab, physical therapy? What role does that have for scoliosis?
Yeah, it looks like Dr. Ravi Yadav asked about it. And the simple answer is we think it's helpful. The most common type of exercises, the big group that talks about scoliosis exercises is called scoliosis specific exercises. And the big one we talk about is called Schroth therapy. That's SCHROTH. The idea behind it is to work with your body and your specific type of curve to help your body rebalance in a 3-dimensional way. So that's what Dr. Schroth came up with. It's been used in Europe for many decades and has kind of taken a more popular stance here in North America recently as well. So I think the role of it is not to cure scoliosis, and we don't think that it stops progression or makes the scoliosis curve better. But we do think that used in conjunction with bracing can be beneficial in stopping the progression. And in some instances, when patients are super imbalanced from their curves, so whether they're shifted off to the right one way or if one shoulder is super low, or if they had a specific surgery to just correct one portion of the spine and the other one is still causing them to be shifted, then I think it has a super important role in helping patients achieve balance and stand straighter and taller and um, look better. But we don't think that it stops the curve from getting worse.
Yeah, I think the data on that is pretty variable. I think if it does help with curve progression, so far we've seen it's modest at best. But like you said, I think in conjunction with bracing, it probably gives you your best shot at preventing things from getting worse. What about Dr. Fitzgerald? Do you like it before surgery, after surgery? Do you have any thoughts?
Yeah, no, I think Schroth can be extremely helpful both before and after surgery. Kind of echoing and piggybacking on what Dr. Hariharan had to say. We know that the Schroth therapy is better for smaller curves. Typically, it has more effect on curves that are less than 30 degrees. We also know from a few studies that it's more efficacious for improving quality of life rather than as much for the curve type. Or the curve size. And we also know that, doing it for longer periods is more helpful than just doing an intensive week or 2 weeks doing it. There's also some evidence out there that it can be more effective if you work with a licensed Schroth practitioner. So in comparison to a physical therapist that's not trained in that or home exercises, if you're doing the true Schroth method, it can be more effective. So I think if you are going to go that route, making sure that you do the research and put in the time are basically my take-home points about it. But for the reasons that Dr. Hariharan said, I like to use it both before and after surgery for patients that are motivated because, again, it can help a lot with that balance component. It can help a lot with discomfort and pain. And in general, like I said, it can improve quality of life. And we've seen that not only scientifically, but we see it day in and day out whenever we talk to our families and our patients that we're working with.
Yeah, and we got a comment from Instagram from Isis Navarro Oficio talking about other types of scoliosis specific exercises. I think Schroth is probably the best studied one in our field, has probably the most data. I think there are other therapies that I'm sure can be helpful as an adjunct. And if you're a practitioner of that type of therapy, I urge you to put your data out there into print, and that way you can help teach others. I think that's how we get better. I'm always very concerned or very wary of any type of treatment that doesn't have a lot of data supporting its use. I think if any type of treatment that says that this is going to cure your scoliosis, but has no, kind of peer-reviewed study to show that it's going to improve you, I would just be very wary of that as a parent.
Yeah. And I can't stress enough how important it is to work with somebody that is trained in one of these scoliosis specific exercises. And I work with a couple of them here, and it's a world of difference. And like you said, Dr. Cho, there's a whole bunch of them, and Schroth is the most well known, probably.
Correct.
And in general, to one of the questions that we got, it's never too late to do exercise. I mean, if you've had a fusion, if you have a small curve, if you have a curve that hasn't been fused yet, that is progressing, any of those patients, exercise is helpful. We know that if you have a strong core and flexible hamstrings, that in general, that's going to improve your issues with back pain. And I talk to my kids that come into my clinic daily with back pain about those things. But the other thing I talk to them about is the importance of the mind-body connection. So that's a great thing to emphasize as you're dealing with these issues. So I think whenever we talk about that, yoga is a great way that we can do all three of those things at once. We can work on flexibility, we can work on core strength, and we can work on that mind-body connection. And there are very few exercises or sports or things people do until they're 90 years old. But I know a few yogis that are 90 years old, and I think it can be really helpful for people's overall mental and back health.
Agreed. I think you're hitting on a good point in that like yoga, Pilates, some of the other exercises that really concentrate on flexibility and core strength, they're helpful for back pain. Not a lot of data showing that it improves scoliosis. So that
Mhm.
question that we got previously as well. Let's see. So we have a couple questions here. So can you, Dr. Fitzgerald, can you give insight on what you think about the role of chiropractors and osteopaths?
So I think that physical hands-on manipulation, the use of that for the same reasons as Schroff and yoga and those sorts of things, that is you concentrating on that core strength, that mind-body connection, that flexibility. I think those things can be helpful. The thing I caution my families about is that while these things can be really helpful in the quality of life aspect, as far as structural rotational scoliosis is concerned, we cannot adjust those things away or strengthen certain muscle groups to make a true rotational deformity go away. And so I think being cautious of that and making sure that you're doing these therapies for the right reasons and not having an inflated hope of a scoliosis going away completely by doing it. But at the same time, if those goals are in line, I think it's an excellent modality that can be really helpful in people's scoliosis journeys.
That was perfectly said, and that's exactly what I tell patients as well. One thing I would like to add is I have seen in certain instances where X-rays have been used to show improvements, and this can include daily or weekly X-rays. And in my opinion, and probably in the society's opinion, that's entirely way too much radiation for children and adolescents. You don't need to be doing X-rays every week or even every month to check on these.
Yeah, I echo that completely. And we've got some really good data out there from Dr. Noel Larson that shows that the radiation burden to our patients that have scoliosis is real and that it increases rates of cancer. Although it still is quite low, it is higher than the matched set of patients. So I think if you do find yourself in a situation where someone is wanting to take frequent X-rays to show small adjustments, I would encourage you not to do that, again, for the radiation exposure component. And remember that even though you have scoliosis or a twist to your spine, you do still have flexibility to your spine. So small adjustments and standing with your spine to the right or left can show changes. It needs to be not a larger change over time. These small changes can be explained by just posture and if you're laying down or those sorts of things.
Yeah, I agree. And as far as chiropractic, I'm friends with Dr. Derek Lee. He runs a pretty large scoliosis related group on Facebook. I had the honor of being actually in his child's surgery, to learn a technique that we'll talk about in a little bit. But for him, he is a chiropractor. And he was frustrated by seeing some of these treatments saying this is going to help, the X-rays, tons of X-ray, but not a lot of data. And so we're very driven. I think if anything works and has good peer-reviewed data, we're all open to look for it. In the Scoliosis Research Society, it's not the Scoliosis Surgery Research Society. We are the Scoliosis Research Society. We want to find the best solutions for kids and adolescents and adults that can help people in the least invasive ways possible. So I'm just going to move on from there, and I want to address. We're getting a couple comments that are very specific to patients, like a particular patient issue. We can't answer any particular patient issues on this chat. If you have anything that is related to your own issue or your own child's issue, my recommendation is in the Scoliosis Research Society, we have a Find a Provider tool, Find a Specialist tool that you can use to help find one of our SRS members. And that's probably your best way to get any specific questions about your condition answered. Good question here. We have Simona talking about what is the impact of scoliosis for other functions like breathing and others. Dr. Hariharan, what do you think?
Typically speaking, especially in North America, we're catching the scoliosis at an early enough age where it doesn't have an impact. And when internal organs such as the lungs and other abdominal organs start getting affected is in severe, severe curves. So in our typical case of idiopathic scoliosis, it really doesn't have enough of an impact to affect a child's ability to do anything. But when the curves go above 90, 100 degrees, that's when we start to worry. The other side of it is, we don't just treat scoliosis. So if a patient has congenital malformations or severe kyphosis, and even if that curve isn't extremely large, then it can have impacts earlier rather than later. But typically speaking, not much of an impact.
Yeah, I agree with that. I think the caveat to that is those early onset patients that we see. So we know those kids that come in with scoliosis early in life, before age 10, these are curves that can get much larger. And it becomes even more of a difficult problem because, we know that should a curve get very large, that we have really good outcomes with fusion surgeries for people long term. We have good 30-year outcome data that shows that people do really well with that surgery. But with patients that have large curves that are much younger, we can't do that surgery yet. And the reason is as spine surgeons, we're not only spine surgeons, we're chest, heart, and lung surgeons. We're trying to protect those things and allow those things to grow. So Dr. DiMiglio taught us that up until age 10, that chest grows exponentially. And with that chest growth, so do the lungs grow, and so do the number of alveoli. And those are the little sacs that we exchange air in our lungs. And so those are the patients that really, this is a tough problem. And making sure that you're going through this journey with someone that has experience and understands these important aspects is key. So please find a provider that can help you through this journey.
Yeah, I totally agree. And, the question about scoliosis and breathing, I think for small scoliosis, totally agree with Dr. Hariharan that smaller, I should say moderate scoliosis probably doesn't affect breathing that much. If it's a very, very severe scoliosis or if it starts very early, then your lung growth is going to be restricted. I think there's been data, older papers that have shown that after about 80 degrees of curvature, you start to get some pulmonary function issues, start to get short of breath, maybe going up steps and such. And then after about 110 degrees, which is a very, very large curve, you're starting to get what we call cardiopulmonary compromise, meaning your heart has to work so hard to pump blood into the lungs oxygenated, you start to see some issues with that. And so we never want any patient to get there. I think that's our goal, is to prevent patients from having difficulties in their life. Like Dr. Fitzgerald said, we have to make the lungs and heart have the best chance for full function as possible. We got a good question about, is it genetic? Dr. Hariharan, do you think that scoliosis is genetic? Can you pass this on to your family or kids?
There's lots and lots and lots of evidence and continuing evidence showing that there is a genetic component. And the issue, however, is they have identified thousands of genes associated with it. And earlier on in the session, Dr. Fitzgerald mentioned, but we know there's a genetic component. We just don't know who has it and how it gets passed on or why it gets passed on. But if a family member has scoliosis, then you should have greater vigilance. And I say this to my patients on looking after your children and future generations to screen for scoliosis earlier rather than later.
Yeah, absolutely. If you have a first degree relative, meaning a sibling or a parent with scoliosis, then you have an 11% chance of getting it yourself. we know that out of all the people with the most common type of scoliosis, idiopathic scoliosis, that approximately a third of them have a family history of the condition for all the reasons that Dr. Hariharan had to say. I think that, you mentioned Dr. Wellborn earlier. The basic science component of this is really exciting because although we're not there yet, there are things that are occurring in that realm that I think within the next 10 years will probably translate to patient care, where we're not only going to be able to get a better sense of who may get it, but who may progress, which I think will kind of change the whole face of scoliosis. And I think the key thing is to continue to be excited about this research and how science can truly affect our patients day to day.
I think one super important distinction to make is, in idiopathic scoliosis is where the data is still, we're working towards these exciting things, but there are certain genetic conditions we know has a super high rate of scoliosis, right? Like Prader-Willi syndrome, neurofibromatosis, some patients with Down syndrome or spinal muscular atrophy. Those all are genetically driven conditions that have scoliosis as part of the condition. So that's an important distinction to make for us.
Yeah, I totally agree. And I saw a patient the other day, and it's a patient that I had done surgery on with scoliosis, and she brought her kid in with scoliosis, and it made me instantly feel pretty old, because I'm treating a mom and her child. But sometimes these things show up in kids, and you want to be vigilant if you do have it. I like you to make, Dr. Hariharan, you made the distinction between adolescent idiopathic scoliosis, which I think has a high genetic predilection or hereditary predilection to be passed on. I think some of the other ones have less of that, like congenital scoliosis tends not to have a lot of hereditary nature to it unless it's associated with some other kind of syndrome, like you said. The question in the comments, Sonia asked, is there any relation between scoliosis and heart valve defects? Dr. Hariharan, what do you think?
I don't believe so. I don't know of any relation there.
Yeah, I totally agree with that. In our typical patient with scoliosis, there aren't issues with heart valve defects. I think the exception to that are people that have that congenital scoliosis that you were just talking about, Dr. Cho. And so what we know is that congenital scoliosis, where you have a triangle instead of a rectangle as a spinal vertebral component, or you have an extra piece of bone that's linking them together, or a combination of those, that typically occurs because of some sort of interruption that occurred between that 4th and 6th week of gestation inside mom's belly. And so the other things that are developing then are the heart and the kidneys and the spinal cord. So we first are not just people that do surgery. We're doctors, and us looking at those aspects are important too. So really has to do with the type of scoliosis, and the majority of them, just like Dr. Hariharan said, does not, but that specific flavor can.
Totally agree. And not only are we surgeons and doctors, but all three of us are parents as well. So like, if we what would we want for our own kids? I think all of us use that as kind of our compass. If I could treat my own kid with something non-invasive or minimally invasive, I would treat my own kid that way, and I would treat my patients in the same way. I think I agree with you that it is very exciting. I think we will figure out the genes associated with scoliosis in my career. My hope is that our clinics become exciting and our ORs become boring, in that we can cure many people with genetic cures. That's my hope in my lifetime. We're just not quite there yet.
I think that's a pretty good segue too, and I'm going to flip the table a little bit on you, Dr. Cho. So we've already been talking for 45 minutes, which is pretty incredible because it feels like it's been a few. But one of the things that we get a lot of questions on, I think people are really interested, is vertebral body tethering. And I think that, all three of us have experience with it, but certainly out of the three of us, you are the most seasoned and the most expert. So can you talk to us a little bit about vertebral body tethering and what your current indications and what the accepted indications are for patients that may be considering this in their scoliosis journey?
Yeah, so now we're talking a little bit about scoliosis treatment. I think it's really important to know. I think if we talk about any treatment for anything in medicine, I don't think there's a one size fits all. I really don't. I think you have to tailor everything individually to a patient and whatever's going on in the patient's life. And so my caution to anybody looking at any type of treatment, obviously do as much research as you can, but remember, not everything is one size fits all. Just in the history of how we've treated scoliosis, I think the most common treatment for most types of scoliosis is posterior spinal fusion. I think that has a very long track record of success. I think most patients who get posterior spinal fusion, they are able to go back to whatever activities they were doing before. I've had kids that were break dancers. I've had kids that were football players, soccer players, baseball pitchers. They all went back to the activity that they went to before. Sometimes kids are in a particular phase of growth that we can consider doing something that's a little bit different. So anterior vertebral body tethering has become very popular over the last few years because it was FDA approved in 2019. This device, the tether made by Zimmer Biomet, was the first device on the market. And that's what we've seen the most in the United States. I would say as we've done more of this and as we've collected more data on this, we realize that the patients that we should do this on really have to be in a narrow window of growth. If they're not in that narrow window of growth, I would say that it's probably going to be less successful. And what do we mean by less successful? I mean, the curve's not going to correct as much, and you're more likely to have a repeat operation. And so for my kids, I've done a spinal fusion on over 1,000 times on children's. I can count on one hand the number of kids I've had to take back to the operating room. I have much less experience than 1,000 for tethering, but if you look at the pooled data from very good surgeons, Dr. Peter Newton, Dr. Feroz Mianji, shows that the reoperation rate is higher for a tether, which makes sense. It's a flexible device. The tether is a flexible device that tries to modulate growth in the spine as kids grow. That number is somewhere between 15 and 40% of revision rate. And so it's not everybody, but I think as we select patients a little bit better, their first study looking at it showed 40%, but that's because we didn't know exactly who probably should get this operation. As we've gotten better, that number came down to 15%. And I bet you as we go on, that number will keep getting smaller because the window in which we should treat these kids is going to get a little bit smaller as well. And so I think it's exciting. It's the first generation of this device that's been on the market. There was an antecedent device, a device that came before the tether called Denosys, and that was used off-label to tether kids. But this newest device is really the first generation. We got a question as well about what companies make the tethers. So the ones that are FDA approved right now in the United States are Zimmer Biomet's tether, and then Globus has a anterior vertebral body tethering device as well. And then there's a third device that's going through kind of final phase of study from Medtronic called Brave. And so those are the three that I'm aware of that are kind of going through the pipeline. When I think about why everyone doesn't get tethered, it's because of some of the data that we're seeing. We're seeing just presented at POSNA, the POSNA annual meeting recently, showing that about 50% of tethers will be broken at 3 years. And so that really highlights that you have to get kids at the right time and with the right amount of curve. Long-winded answer, but I think it's an exciting technology, but the right patients have to be chosen. Dr. Hariharan, what do you think?
That was an extremely exceptionally well answered question, Dr. Cho. Very comprehensive. I agree with everything. In my opinion, I think it's very exciting to have new technologies and new ideas that not only modulate growth, but potentially and we're not totally sure about this, is to save motion in the spine. We're getting better at it, which is why I think the revision rates and the reoperation rates are better. And I think we're choosing patients more appropriately. And I, like you, am only doing it in these studied patients where it has been shown to be most effective. And outside of that, it's hard to say what the value is and what the reoperation rates are and what the motion preservation are. But I think as with any new technology, you got to stay within the bounds of what's been studied and what the leaders in the field have been teaching us on how to do these.
Yeah, I agree. I think the growing kids, I think we have good data to show that it can help some of these growing kids get their curves better. If you don't have growth remaining, then any device that's implanted in the body, especially if it moves, at some point is going to fail. I think it's the current device that we have, which is a flexible PET, a plastic tether, basically. It's a rope. I don't think it's quite strong enough if you don't have growth remaining. Like, the goal is we know that rope is going to break probably at some point. We want the spine to get as straight as possible before that rope breaks, because then if the rope breaks, then the spine's already straight and you've had a good result. If that rope is consistently under load because you're not growing anymore, that rope is going to break. It doesn't matter if you have one rope. It doesn't matter if you have double row, 2 ropes. It doesn't matter. You can put 1,000,000 ropes in there. Currently, the technology is not quite strong enough. The fatigue life is not strong enough for me to support it. And I would say most of the Scoliosis Research Society is the same. Dr. Fitzgerald, what do you think about, we talked a little bit about spinal fusion. What determines when you would fuse a kid? Is it the Sanders stage, severity of the Cobb angle, type of curve, all the above?
I think it's all the above. I mean, I think it really depends on the patient's problem and the situation at hand. So the majority of patients that we've been talking about are the majority that we see that need surgery are people with idiopathic scoliosis. And so based off of our Iowa natural history studies, we know curves that are over 50 degrees are ones that are more likely to progress long term. And typically that progression is by about 1 to 2 degrees per year. So short term, over the course of 5 years, for somebody that's done growing, the chance of that progression to a large amount is very low. And so it makes it a non-emergent sort of situation. But the conversation I have with families is, if you have 10 years of growth and let's say their curve has progressed 20 degrees, the downside of waiting that long is a couple things. Number one, they may have lost that balance where their head's not over their pelvis anymore. That can lead to significant discomfort. The second thing is that as that curve gets larger, we may have to fuse a larger portion of the spine. And with fusing a larger portion of the spine, you lose motion segments that not only affect your mobility, but also affect area that your spine naturally dissipates forces and puts more pressure on those other areas you don't fuse. So typically my recommendation as a discussion with the family is, if you've gotten over that point, we know that's the natural history. While you're younger, healthier, have more social support, less responsibilities, we can do a surgery for you that has good longevity, get you balanced, get you fused, and let you move on with your life. But again, that comes down to a patient and a family discussion, because let's say you have a lumbar curve, you're done growing, you're right at that 50 degrees, you're not horribly off balance, and you're a high-level gymnast. I think for that specific patient, it may be reasonable to wait until their gymnastic career is over to do their fusion, as long as they fully understand all the ups and downs. So it really is about getting to know the patient, getting to know the family, getting to know their goals, and helping guide them through that. And I think our jobs as surgeons, which the three of us know, but not everybody that comes into our office does know, is our job is to teach you about the science and let you know the things that we know about it so that you can make the best decision for your care. And our goal is to educate you. That's the basis of what physician is education in Latin. And so hopefully you can find somebody that can help you through your journey with those decisions.
Yeah, I love that. I mean, I'm a big believer in, I will, if it's within reason, I want to work with families to provide a care plan that works for them. I think, a question we got for curves in the low surgical range around 50 degrees, should you fuse that kid as a teen? You addressed that nicely, Dr. Fitzgerald. It's, if a kid is very active, if gymnastics is their life, or, I don't think as long as the curve's not super progressive, you can wait. I think that's totally reasonable. And I have plenty of kids that are in that surgical range that I don't operate on. And
Yeah.
I say, you're done, or when you have a time that you feel like, you can take care of this, then I think it's reasonable. But, we'll have a different conversation if that curve, continues to get worse. Then we think, what, that snowball's rolling down the hill. We probably need to take care of this.
Yeah, I think the key word you said there was the progressive or not progressive component. And so that's the other component. If you hear, hey, 50 degrees, we don't need to rush to surgery on that. That's true for some patients and never should rush. But for somebody that is in a fast growth spurt where they're progressing quickly, doing a surgery at 50 degrees may be more helpful than waiting 6 months and now they come back at 70 degrees, and let's say we have to fuse 2 or 3 more levels, or the lumbar spine becomes a structural component now that we have to address. That's a completely different ball game. And so that's an extreme nuance that may be tough to navigate, but that's why having someone in your corner that understands those nuances is really important.
Yeah, I totally agree. I think it's, it's hard to know, and there's so much information on the internet. You want to get someone you trust that you can talk to. Someone who's on the internet, they may not be physicians, or they may not have the latest data. You really have to be careful who you receive your information. All of our Scoliosis Research Society members are vetted. It's actually quite a difficult process to become part of the Scoliosis Research Society. And so anyone who is a member of the Scoliosis Research Society, I'd feel comfortable taking my own family to. So Dr. Hariharan, I'm going to give you kind of a tougher question. What's the difference between vertebral body tethering and anterior scoliosis correction, ASC?
Yeah, that's a tough one. Thank you. So VBT, we've been talking about it for a while. It's the original brainchild on this growth modulation or flexible scoliosis correction. ASC, anterior scoliosis correction, is done by a specific set of surgeons who focus on doing this in skeletally mature patients. So patients who have completed their growth and don't meet the VBT criteria we talked about before. So that's somebody with a curve magnitude within 40 to 60 degrees and still has several year or so of growth remaining. The ASC patients, on the other hand, can have either bigger curves or no growth remaining. And where the difference lies, it's the same idea of putting screws through the side into the bones and putting a tight rope in there to correct the curve. But little nuances include cutting part of the disc to help correct the scoliosis a little more because the patient's older and more rigid. The difficulty in answering this question is the data supporting each of those things. So VBT is extremely studied. If you look at the chart on the number of patients or the number of studies that have been presented at SRS, POSNA, or other scientific meetings, VBT is at the top. As far as ASC goes, we just don't have as much data on it. And really, if you go on PubMed or look for articles that have been published on it, we don't have it. There are well-known surgeons in the country that are doing it and across the world, but it's hard to say without the data to support it on how effective it is or what the reoperation rates are, or if it really works for these patients who don't have any growth remaining.
Yeah, I totally agree. It's one of those things. I'm a big believer in data, and if it is a good procedure for patients, I look forward to seeing the data and incorporating that into my practice. I have not seen it yet. I have not seen a single peer-reviewed study that supports ASC yet. I'm a little concerned cutting a disc, which is, I think, a primary stabilizer of the spine. If you cut that disc, if you know anything, all of us do discectomies. I've done revision discectomies on kids, and you can see exactly where you cut open the disc from the first surgery. So anytime you cut a disc, it doesn't really heal that well. I have 2 kids in my practice who've had ASC in the past. They broke their rope, and they because that disc has been cut, they're unstable through that disc, and they have some pretty severe back pain. So it's something that I think right now, without data, it's hard for me to recommend. I think if the data comes out supporting its use, I think I'm all for it, but it's just not quite there yet. Dr. Hariharan, you have any consideration for the lungs during a VBT surgical procedure, and what are the risks?
Great question. Almost very little concern, and there's good science behind this. If going through the chest and reinflating the lungs while you do it, and it's not a prolonged surgery, then really very minimal impacts. There is going to be some scarring, so if there's going to be a need for revision surgery, it makes the surgery a little bit more difficult, but as far as lung function and breathing goes, not a significant impact.
Dr. Fitzgerald, what about other devices like the ApiFix? I think Rahul in our comments asked about what is the success rate of non-fusion techniques like ApiFix?
Yeah, it's a great question. And I think, to be honest, we don't know yet. And so if you're considering ApiFix, you really need to have a good conversation and understand with your surgeon not only the indications, but what we do know so far. So as time goes on, this is another non-fusion procedure. It's a posterior-based procedure, so it's through an exposure that we typically use for fusion surgery. But our goal is not to turn those individual building blocks into one long block. Our goal is to hopefully use this as an internal brace to try to prevent progression of your curvature to the point where it would need a fusion surgery. And as of right now, it's about somewhere between 10 and 15% revision rate for ApiFix. But again, that's on very short term outcome data. The current type of ApiFix, it's the 4th generation. So that first started being used in 2017. So to really get good long-term data on it, it's going to take more use. It's more of a question of what your goals are, and if you're willing to take that risk for the effort of trying to save motion segments.
Yeah, I think that's really well said. I think, again, it's a new implant, needs data. The biggest study, I think, looking at it, looked at early generations of it, the 1st and 2nd generation, I believe, and the data wasn't great. But that said, with this newest generation, is the data going to be better? I mean, perhaps, but I think it's too early to say.
Yeah, and I think with that, the key thing with ApiFix that I think that what they're doing well is they're collecting the data well, so we know exactly what's going on. And I think what can be said about that is true and should be taken for all sorts of new procedures like, lumbar tethering, ASC, those sorts of things. You need to be educated before you undergo those things. You need to be going to someplace that's doing a good volume of it and collecting that data so we can not only better take care of you as the patient, but better advance what we know about it for future generations. But kind of general things about ApiFix, it's for idiopathic curves that are either just in the thoracic or just in the lumbar spine. They're smaller curves between 35 and 60 degrees, and they have to be flexible curves that don't have too much forward bend through them too, because this device requires motion to be dissipated through 3 different points. And so if any of those points are blocked, it can cause issues with the device and breakages.
Absolutely. All right, we're just going to change tack a little bit. I'm looking at some of the comments. So Angus asks about what about scoliosis during pregnancy. I'm going to answer that a little bit just because we have a paper that just came out in spine deformity looking at, we looked at the Kaiser database of hundreds of thousands of lives, looking at what happens to patients with during pregnancy, if they've had a spinal fusion or if they have not had a spinal fusion actually. And what we found is that in general, patients with scoliosis who get pregnant are able to have children, healthy children, just fine. The patients who had surgery, the thought, our hypothesis was that it would, we thought that those patients would be less likely to get epidural injections because, some of that space has been used for surgery. We actually found the opposite. The patients who had surgery in the past actually had higher rate of epidurals than the non-treated patients. And so, that was a little bit of a surprise for us, but I think it's because patients who have had scoliosis surgery had good access to care, and those patients are a little bit more tuned in with their doctors. And so you are able to have an epidural injection for most surgeries in the future for pregnancy. Like I said earlier, that I had a child that I had operated on that became an adult and had their own child, and they brought that child to see me for scoliosis. So you can have kids with, you can carry baby to term with scoliosis. The rate of C-section was not significantly higher for patients who've had scoliosis. That was also a surprise for us too. So, it's, for us, it's looking at the data, and sometimes we have preconceived notions of what happens, when you have scoliosis, and then it's only when you look at the data that you see things that are a little different. So
Elliot here in the comments asked a good questions about resources for patients and their families, essentially, and I think this is a great place to shamelessly plug the SRS. I think that, like we alluded to earlier, if you Google scoliosis or you Google vertebral body tethering or you Google a specific topic in the spine world, you may find all sorts of information. And some of that information may be good or some of it may be bad. But the Scoliosis Research Society really puts in a lot of effort to make sure that the information that they're giving is science-based and factual. And so I encourage all my patients and anyone that's watching this or is interested to look at the SRS website. We have a committee that works on this year-round every year to try to make it navigable and appropriate and factual. And there's good patient and parent sources there. There's other groups that do this as well. So Setting Scoliosis Straight's another great one. The Pediatric Spine Foundation for kids that are younger than 10, or the Pediatric Spine Study Group, they have good information as well. And so I would encourage you to look at those places, but also partner with your physician that you're working with, because they may have other good sources of information for you as well.
Yeah, and I think that's a good place for us to wrap up. I can't believe I'm talking for more than an hour. Dr. Fitzgerald and Dr. Hariharan are friends of mine, and we do like to talk about it. It's amazing that we were able to talk about this for so long. There are probably other questions we didn't get to. Our goal with the Scoliosis Research Society is to try to create more patient-facing events like this so that you can ask an expert, like you have questions. Our goal is to try to show you as, what we think and why we think it. This is, the thing that I hope I get out from the Scoliosis Research Society to the group, and I'm sure Dr. Fitzgerald and Dr. Hariharan feel the same, is that we are scoliosis doctors, not just surgeons. We want to make sure that we treat the entire envelope of care. If I can prevent surgery on a child, I will, and I'll treat every kid just like I would treat my own kids. I want to thank Dr. Fitzgerald and Dr. Hariharan for their time. And I want to thank Sean Story from Scoliosis Research Society for providing all of the behind the scenes help to make this incredibly seamless. We will continue to have more of these in the future. Thank you so much, and look forward to seeing you all soon.
Thank you, Dr.
Thank you very much. What a great opportunity, and thanks to all our patients. Shout out to all the scoliosis warriors out there.
I echo that. Everybody have a great weekend. Thank you.